Okay, good morning, everybody. In the interest of getting started on time, we're going to go ahead and begin and assume that other people will be joining us as we continue on. Welcome this morning to the Power of Persuasion, a webinar presentation facilitated by Acumentra Health and hosted by the Patient-Centered Primary Care Institute. Before we get started today with the presentation, I want to talk a little bit about the technology we're going to be using. So everyone who's on the line today is currently muted and will remain muted during the presentation today. We do, however, really want to hear from you and answer your questions, and there are a couple of ways that you can do that. So the first way is during the presentation or when we open things up for Q&A, you can type your question into the questions log on your control panel, which you'll see up here on your screen. We welcome questions that way. I'll go ahead and read them for you, for the presenters, and they will answer them. The other thing that you can do to ask your question, and we really would like to hear from you, so if you would like to, you can also use the hand raising feature. So when we call for question and answer time, you can click the little hand on your control panel. That shows me that you have a question. I will introduce you, unmute your line, and you can ask your question to the presenter yourself. So why don't we just go ahead and see if everyone's awake this morning. So if you can hear me and the sound quality is good on your end, why don't you practice raising your hand right now? Let's see if people can use the hand raising feature. All right. Good morning. I see some people out there can hear me, so perfect. We've made sure that is working. I do want to let everyone know, because this is a question we get all the time, that we will be sending a recording of today's presentation and the slides out to everyone who is on the call today. So no need to check in about that. You'll get that in your email box, and you can also visit the Institute website to access those materials. One other thing, technology-wise, that I want to let you know, to engage you in the presentation today, there's a poll question that will happen in the middle of the presentation. And so a survey will come up on your screen, and you'll provide an answer, and the presenter will use that to continue on with her presentation. So there'll be a little bit of interactivity during our hour together today. All right, let's go ahead and get started here. So the Patient-Centered Primary Care Institute was launched in 2012 as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and the Oregon Healthcare Quality Corporation. The Institute's goals are to provide a broad array of technical assistance for practices at various stages of primary care home transformation, and to be an ongoing mechanism to support practice transformation and quality improvement in Oregon. One of the ways that we're doing that is through a learning collaborative. We're working with 25 practices throughout the state. They've been assigned technical assistance providers and practice coaches to help them in their transformation process. We also have online resources. This webinar is one of them, so a recording will be available on the website after today. And then we hold monthly webinars, and you can register for those through the website. In addition, we'll be adding resource materials to the website in the coming months, as well as some online learning modules in the spring, and those will be available to the public, so you want to check back for those. The best way to stay on top of what the Institute's doing is to sign up for the newsletter via our website, and we'll announce in-person training opportunities, online, new things that are online through that email list. So just briefly, you can read more about Oregon's model of primary care home on the state's website, which is linked at the bottom, primarycarehome.oregon.gov. But Oregon's PCPCH model is defined by 6 core attributes. Those are access to care, accountability, comprehensive whole person care, continuity, coordination and integration, and person and family-centered care. And we encourage you to get more information about the state's primary care home program from their website. So with that brief introduction, I'm going to turn things over to the folks at Acumentra to get us started on our presentation today. And it looks like we might be having a little bit of trouble with the audio. So give us just a second here, and we'll transfer over to the folks at Acumentra. Sorry, give us just another moment. We'll see if we can get the folks at Acumentra on audio.
Kate, can you hear us?
Oh, we can hear you now, much better.
Okay, I'm sorry about that. So thank you for the introduction, Kate. My name is David Caress, and I'm a Quality Improvement Specialist at Acumentra Health. We're at Acumentra Health are very excited to be partnering with the PCPCI Institute, as well as medical and mental health providers from across the state to work collaboratively to build capacity and create alignment. As the Oregon healthcare delivery system continues to innovate towards assuming greater accountability for costs and outcomes through programs such as CCOs and PCPCI homes, successfully engaging patients in their care has become increasingly understood to be a critical factor in achieving the triple aim: improving the patient experience, improving the health of populations, and reducing the cost of healthcare. A growing body of evidence has been published in the current edition of the journal Health Affairs, has linked patients' engagement to their health and cost outcomes. Engaged patients are more likely to participate in preventive behaviors such as having regular checkups, screenings, and immunizations. So, for anyone who is not familiar with Acumentra Health, we serve as Oregon's CMS-contracted quality improvement organization to foster improvement, quality, and safety throughout Oregon. Current projects have us working on with hospitals, nursing homes, pharmacies, communities, and outpatient practices. We also work with managed Medicaid programs as external quality reviewers to ensure plans meet state and federal requirements. For a full list of our current activities, I invite you to visit our website, which is listed below. Today we are going to hear from Dr. Ruth Medic and each other on some of the barriers we face in engaging the patient populations, as well as strategies to help overcome those barriers. Dr. Medic, as many of you may know from your work with her, has been providing clinical care and quality improvement throughout Oregon for over 15 years. She currently not only works on a diverse number of quality improvement projects here at Acumentra Health, but also works closely with patients and families for Providence Hospice and Home Services. Dr. Medic, would you like to take it away?
Good morning, and thank you very much for giving me the opportunity to speak with you today. Our learning objectives are that participants will be able to describe two important barriers to patient engagement in self-care, because frankly, you're not going to make any changes unless you really look at yourself, look at how you've been doing things, and determine what you will change to be a more effective practitioner. And we sincerely hope that you will not only listen and learn, but that you will take to heart those opportunities and really implement new tactics for influencing patients to achieve not only your goals of care, but their goals of care. So I sincerely hope that you'll understand how engaging patients will help you meet all of these goals and really improve the health of your entire practice, and with all of us doing this, the health of all of Oregonians. So our vision, that is healthcare providers' vision, remembering that I am also a healthcare provider, is that all patients achieve and maintain the best possible health status. And our vision at the Institute and here at Acumentra Health is that provider teams work closely with patients to develop collaborative care plans. And that is really the operative change in the practice world as compared to when many of us were trained. We were all trained to tell people what to do, but we know that that hasn't worked very well. So moving on to what we know is a better vision, what we know is more effective, is to move to engaging patients in developing care plans and being actively engaged in their own care, because although doctors and other health providers think that we manage health care, anybody who's been a parent of a person with any kind of condition, or the child of a parent who has chronic conditions or themselves has them, knows perfectly well that the patient's in charge, that the providers make recommendations, the providers offer guidance, but essentially the patient does what the patient wants. So our goal is to help the patient want what's good and commit to what's good and to achieve the health that we and they wish them to have.
So patient engagement in primary-centered primary care homes. As we reviewed the standards and measures, we see a great deal of direct alignment between the patient engagement and the performance and clinical quality measures that we see in some of the measures listed on this slide for both the core and menu set of measures. The research that we have seen shows in multiple studies as patient engagement increases, so do many of the clinical measures listed in the core and menu sets of the PC-PTH measures. Patient engagement will also help you work with your patients to deliver the recommended age and gender-appropriate preventive assist services listed in Measure 3A of Preventive Services. So there is some direct alignment between patient engagement and the medical homes that many of us are trying to achieve.
When you talk with providers, and those of you out there in the audience, you know that the greatest frustrations are what we call noncompliance. Oh, that's a kind of a lousy word, and we certainly don't apply it to ourselves. But noncompliance, non-adherence. We see people exercising poor health behaviors. And worst of all, we see the consequences of that with avoidable complications like strokes, heart attacks, blindness, amputations, etc. Or even people getting a serious bout of the flu because they didn't take a flu shot, or a cancer that was diagnosed at late stage because they didn't get a screen. So our job is how to influence people to do the things that we believe are important for their health by getting them to want to do them. So why don't patients follow your recommendations? I like to look at our own daily life in order to get a better understanding of our patients, because after all, most of us at some time or another are patients, and we have the same bad responses to recommendations that our patients do. So thinking about your own life, I wonder how many of you do your taxes early and how many get them done on the last day. You used to be able to get them done at about 11 o'clock at night, but these days it's a little tougher to get them postmarked on time. How many read your journals on a regular schedule as you intend? Or do they stack up in the I should be reading them pile? What about the garage? When your spouse asks you to clean the garage, does it get cleaned that day? Or does it kind of wait? And then you get nagged, and you get nagged. Boy, that sounds a lot like a primary care provider, nagging. You know, why aren't you taking your medicines every day? How come you haven't lost any weight? Why are you still having those terrible blood sugars? Exercise is the same. And our own diets, not just the patient's diets. That extra 10 pounds we picked up over the last year or two that stays there instead of going away because we keep doing the bad things. So we have a lot of lessons to learn from ourselves and our families as to how to motivate patients. So as one example of that, I'd like you to think about how is recommending colorectal cancer screening a bit like asking your child to do homework. So think about that. Ponder that a moment. And this wouldn't 2015 be soon enough probably gives you the point of what I was thinking. And that is that one of the problems with asking your child to do their homework is that you could either yell at them and say, you know, would you please get your homework done? Or you could put it in a context that makes them want to get it done, such as, gee, seems to me your favorite television program's on at 9 o'clock, and you can watch the program if your homework's done. Suddenly the motivation is a whole lot better. Well, you can't threaten your patient about colorectal cancer screening, or sort of can you? The first thing is that you can agree on a plan with them. That is, that they agree when they can complete the test. For instance, most people can get their test done in about 2 weeks if it's a fecal occult blood test. So can you agree to get this done and back to us, let's say, by March 1st? And if the patient agrees, write it down on the fecal occult blood test. And then, by the way, if it doesn't come back, we'll be calling you. So you've set up an agreement that the patient has actually agreed to on when something will be completed. There's a clear expectation of when it will be done, as opposed to, here's your fecal occult blood test, would you please send it back to us when it's done, which is like, would 2015 be soon enough? And then lastly, you've made a follow-up. That is, expect that there's a consequence. If it's not done, we'll be contacting you. So colorectal cancer screening recommendations actually do have a lot in common with getting kids to do their homework. You need to set up expectations. You need to be very clear. You need to get some buy-in so there's something in it for them to do it. And then follow through. So overall, in life, it's always about what's in it for me. This is not unique to patients. Same thing for us. Why do we do things? We feel good about it. There's some kind of reward in some way. You get your taxes in late, you have fines. Very bad thing. Or conversely, you bring home flowers on for Valentine's Day and take your wife or your significant other out to dinner. Sorry, I'm being a little chauvinistic here. As a female, that's a little odd. And you get rewarded. Your partner is happy. They smile at you. They are extra nice. So frankly, we're all motivated by what's in it for us. And we need to work with patients with that in mind, that when we're asking them to do things, particularly things that are a little unpleasant, things that require commitment, it's very important to figure out with them what's in it for them. And part of that is understanding the patient. The other part is just understanding human nature. So we have to think about, is what we're asking to do compatible with beliefs and culture? And certainly anybody who lives in Oregon knows that flu shots are one of those things that may be really compatible with beliefs and culture, or a real stretch. And whereas someone may not believe in it for themselves, they may be willing to do it because of the impact on their children, on their parents, on relatives or friends who are frail. So it's using the ammunition you've got to help to convince them to do something that they may not really want to do for themselves, but is nonetheless important. And ultimately may be important for themselves even though they don't realize it. My personal conversion to flu shots 20-some-odd years ago was as a person who just doesn't hardly ever get sick enough to notice. A friend of mine who was extremely fit, swam every day, lifted weights, bicycled, was in just incredible physical condition, and about 40, got the flu dreadfully. And he was just laid out and sicker than sick. And I decided, well, if he could get that sick, I should probably start taking the flu shot. And that was long before we really put on the push that by everyone, as many as possible, getting the flu shot, we would create herd immunity, and there'd be fewer outbreaks, and fewer of the people who actually couldn't recover from the flu would get it. So our public health push has been considerably different in the last 20, 25 years. And most people realize why we push for the flu shot. But again, think of, for me, that was the trigger. For your patient, it may be a different trigger. And the important thing is to think about what is important to that person and align your ask with what's important to that person in front of you. And again, what's in it for me, how it helps me achieve my life goals. And if you think about this, this may be the business of an older person looking forward to retirement, and they want to be healthy for their retirement. And so aligning taking the medicine for their blood pressure may have more impact if it's about being healthy to do all the things you've put off that you're planning on doing after you retire. But again, the messages are going to be different, and the more you know your patient and you understand what will motivate your patient, the better you're going to do with getting people to adhere to all the really not so wonderful things we ask them to do. We ask them to take medicines multiple times a day. We ask them to control their diet, which in a world of food cues and wonderful things to eat that are available, ready-made and in restaurants and fast food, it takes a lot of different interests to say no to something you want, to say yes only occasionally to something you want, and to every day do the things that aren't so wonderful. The exercise, the hand washing 50 times if you're in the healthcare, etc., and so forth. And the last thing is thinking about your patients. How many times do you ask them to do things that really aren't feasible, that they can't do? And do you really know? So this comes back to all of these things are about talking with your patient, listening to your patient, asking important questions such as, okay, I'd like you to take this medicine 3 times a day. Can you do that? Is that something that works for you? Because if not, we do have some other options. Is a person able to go walking? Or do they live in a neighborhood where it really doesn't work? There are no sidewalks, or they don't feel safe. And really important to engage the patient in the conversation and to normalize the discussion that says, I can't do that, or we need to talk about something different. It's not going to work for me. Traditionally, we do things like ask, do you have any questions? Well, a lot of people who have questions won't ask when you ask that way. You need to do things like saying, most people have some concerns or questions. What are yours? Or there are many other ways to do that. But to understand that if you don't make it easy for people to say things that they think you don't want to hear, they're not going to. And one of the things we've not been very good at over the years is allowing people to buck our authority, to basically sit in the patient chair as an equal who is engaged in making a plan, in establishing how they will treat whatever it is, whether it's preventive care or high blood pressure or diabetes or whatever, or asthma or whatever it is, but that it's their life, and we are the coaches, we are the expert providers of advice and of information, but they're the ones who have to do it, and the plan has to work for them, not for us. So the other thing about beliefs are risks and benefits. Remember that what we see as a risk may not be something that they find particularly scary, like getting the flu. Many people think that it's much riskier to have the vaccine than to get the flu, which sounds great unless, of course, you happen to have asthma or unless you happen to be an old person where you might die. And again, what we see as benefits aren't necessarily what the patient sees as benefits. So what you keep hearing from me is that you need to understand your patient, you need to listen to your patient, and you need to know enough of what they value to align what you want them to do with their values and their goals. Source of health sounds like sort of what in the world could I mean by that? But we, that is the people in this room, in this conference, probably all believe we have a huge amount of control over our health. But that isn't true for everyone. There are many people who feel that health just sort of is. It's something that you're given, and you're either lucky or you're not. And to some extent that's true, but we have a fair amount of control. And so again, understanding the locus of control, what your patient believes about the source of health, is very important in terms of what kind of information you give, how you give it, and whether they're likely to adhere to a care plan, even if they've worked on it. Cultural and religious beliefs. I'm going to probably hit cultural would be things we've talked about, but religious beliefs may be that people see their body as given by God, and they need to take good care of it. That's just one way of looking at it. The other thing about beliefs is their duties toward their children, their parents, and their community. And so again, maintaining good health so that you can fulfill those roles and those duties can also be a powerful incentive for people. And the other aspect of community may be your work in the community. If you're a volunteer or a worker, you're obviously the breadwinner, or you may be the caregiver. So those are other things that are highly motivating. If you really align, taking your high blood pressure medicine will keep you healthy so that you don't have a stroke, you don't have a heart attack. You will be able to do things that are important to you and make you feel better. You know, with diabetes, it's not just that you won't have complications. You feel better. And again, have the energy to do the things you value. So again, we have a huge opportunity to align the things that are important for health with the person's own values, their own goals, and they will be far more engaged in any plan when it aligns with their goals and when they've had a role in choosing, because there's never just one way to treat something. There are multiple medicines, different side effects, and again, the patient may choose that certain side effects are less acceptable than others. So engaging the patient with choices also is incredibly important in their adhering to the plan. Those of you who pay any attention to the media, you know, we used to think it was just African Americans who didn't trust the health system. That is obviously not the only group. I would say vaccinations. If that is not evidence of people not trusting the healthcare system and not trusting science, I do not know what is. In addition to that, we have people who have alternative views of what is healthy treatment. You know, whether it's high colonic enemas or herbs as opposed to allopathic medicines. So there are lots of different belief systems, and it's really important to keep those in mind because there may be some alternative approaches that may be effective and that your patient would follow. I mean, one example is the breathing treatment yoga for high blood pressure. It actually can be effective for modest high blood pressure, and certainly something should be investigated if the patient is attuned to that style of treatment. So again, getting out of our little box of just doing things the way we were taught. So the impact of beliefs. I'm healthy, I never get sick, why do I need a flu shot? Again, you've all heard this, I don't need to belabor this point, but certainly it has a real impact on what people do, their own beliefs. Nobody in my family has ever had a heart attack or stroke. Why do I need to take my statin drugs? Well, it's all well and good that your parent didn't have a heart attack. One of the things that it reminds me of is there was a family physician in this town who had coronary disease in his 70s, 80s, and had a bypass and did extraordinarily well. Unfortunately, his son had a heart attack while jogging and died in his 40s. So you can't count on, just because your family hasn't had disease at your age, that if you have a lot of risk factors that you can skate by. And that's a hard thing, because we'd all like to think, you know, we don't need to get a mammogram because nobody's ever had breast cancer. We don't need to get a colorectal screening because, after all, nobody's ever had colon cancer. But an awful lot of those conditions only have a modest hereditary component. So again, how are you going to make your case? For colorectal cancer screening, one of the docs that I have worked with had a couple of unpleasant experiences where people decided they didn't need to get screened. And so when they had their first screen, they found advanced stage colon cancer. And that really, really got to him. And so part of his pitch was, you know, we'd like to start screening at 50, and I want you to do either colonoscopy, or if you can't do that, then let's do an occult blood test because, or a stool test, because I don't want your first test to be the test where we find cancer. I would much rather we found a polyp and prevented a cancer. And so again, think about yourself. What are your own experiences, or the patient's experiences, that you can bring to this discussion that will alter their perception and help them do the thing that is good for them and healthy for them, and will keep them in, you know, functioning at a high level for a much longer time. And by the way, he says it's a very successful strategy. That it's like stories, any kind of story. We all respond to stories, and so using those stories in your practice, in at least this abstract sort of way, can be really helpful in bringing people around. And of course, the other thing is finding out what stories they've heard and what makes them feel the way they feel. What have their experience has been? Their friends, their family members, themselves. Because their stories may in fact be full of false information or very valuable information. But either way, you need to know what the stories that are guiding their lives are in order to try to help them get the preventive care they need, get the treatment they need, follow through with treatment, like again, taking medicines every day, doing exercise every day, following a decent diet, because nobody's going to follow a perfect diet if they're not obsessive compulsive, but it has to be good enough. So of course, you know, medicines are expensive and have side effects. How often do you look at the costs of medicines? Do you actually think about alternatives like a generic that would work as well, that is more modestly priced? How often do you ask patients about what they can afford? You know, whether the copays, you know, do multiple copays really make it impossible for them to take all their medicines? A lot of people have insurance, but still, the copay for a trade name drug can be substantial. And if their finances are limited, they may not take their drugs, or they may take them erratically. I think for too long, healthcare providers have been fairly oblivious when it comes to the impact of those copays or the costs of medicines or the costs of being off work for a test or whatever. And we need to be, again, this is part of work with the patient, understand the patient's life. And I realize it's not like you have a whole lot of time, but it's listening enough and recording that information so that you may get all your information over 5 visits or 10 visits, but record it so it's there so you know who that patient is. And of course, we all know that quitting smoking is one of the hardest things. It's one of the most valuable, but it's also one of the most difficult. And again, sometimes the reasons that people don't quit are like this. It's because they gained weight. It's not just that they were having trouble. So again, important to ask the questions. What have been the problems in the past? And then we had a program on the Oregon Quit Line. And I would encourage you, if you don't know much about the Oregon Quit Line, please use it, learn about it, look it up. It's really a great, great service. And if you're talking about being efficient in an office practice, making a referral to a program like this that will take most of the burden off of you is a tremendous opportunity. Because this is, frankly, one of the best things you can do for your patient is to help them quit smoking. When you think about all of the risks associated with smoking, cancers, heart disease, chronic lung disease, etc., it's really a biggie. So you have to listen to the patient to decide even what to recommend, how to make your best case, and to engage the patient in the discussion. This is not like a half an hour discussion, but it's really, it is worth 2 minutes to talk with the patient and get their input. Again, if they are engaged in the discussion, if they are engaged in the decision-making and commit to doing it or commit to trying it, and that's another thing to think about. If the first thing is, when you have someone coming in with a chronic disease, how often do you remember to tell them, this is forever? How many people do you think, it's extraordinary, how many people don't realize when they are told they have heart failure that this is not a temporary condition they're going to get cured of? Or that with hypertension, most of the time people, once they have hypertension, continue to have a need for blood pressure medicines. There are exceptions, I understand that. But in general, we're not so good at explaining the things that to us are so obvious. And so this helps people also in understanding about why they should become engaged in their care, that it isn't going to go away, that they need to manage it. It's their life, their disease, and they will be the manager ultimately. We will be the coach, they will be the manager. So again, since they're really the managers, they need to be committed to the plan. They need to help make the plan. And remember, it isn't just the patient. It may be the family member who does the cooking, who has a huge control in diabetes. It may be the family member, the wife, the husband, the child, who puts out the medicines. So they're at the breakfast table and the dinner table. So remembering that people aren't just islands. Engaging the whole family is really important in many diseases. And I would say anything that involves diet, if you don't engage everybody, you can get sabotage. And even if the person would like to be making good choices, they're going to have trouble. And it may be, for instance, that the spouse is my brother-in-law. My sister is overweight. My brother-in-law is a fabulous cook. He doesn't have any problem with his weight. And I would say, frankly, he does a little sabotage. He cooks with high-fat, wonderful meals. And this is not an unusual thing because, you know, in a way, your identity is wrapped up in being a good cook and making fabulous meals. Not a unique situation. So engaging the whole family can be a really important aspect of achieving good health for all of your patients. So when you have a discussion with the patient and family, you have to really hit all of these things. What are you asking the patient to do? Why? There's some really great decision support tools. We'll show you one in a moment. When? This is like, you know, do we have to take this medicine forever? Do we have to take medicines forever? And what happens if you don't follow through? Something we also haven't been so good about is doing this thing called a teach back. That is where we ask the person to tell us what is your understanding of A, your condition, B, what I asked you to do. And what is just fascinating is what people understand, which may be totally different than what you thought you conveyed so elegantly. And it's really worth trying. And that goes back to the what do you want me to do and for how long? Consider that sometimes if you present something as a trial, not just we're going to try this medicine, but I'd like you to try this strategy. You're not committing forever until you agree to commit forever. People will often say no to something, like maybe yourself, like thinking about providers, trying a new way of doing something, or trying a new order set, or a new template. You're much more likely to say yes if we're going to try this for a week or two and see how it works and get some feedback and decide if this is something we want to continue or do we want to revise it. So again, lessons from yourself. If it's a major change, it's really tough to say, oh yeah, I'm going to do that. Much easier to say, I'm willing to give it a try. So consider that approach with your patients as well. So the other thing is that you have to be really honest with people. You know, if there are unpleasant side effects, don't waltz around the question. Be honest. Tell them what the side effects are, and which also means that again, there will be some patients where maybe that's not a good idea, but 95% they'll want to know, and they'll also be more likely to tolerate them if they know that they're unpleasant but they go away. But if you don't really warn them, then they may just stop. And then for decision-making, there's this thing about using decision-making tools. And we're going to show you one that's rather interesting. And Mayo Clinic has some great tools, and so does this other site, Informed Decision-Making. So for the Mayo Clinic here, you notice this is for using statins. And what it has is it's set up a very visual display of the benefits for people at average risk, at elevated risk, and at high risk. So we're first going to show you what it looks like for average risk. Come on up, guys. It seemed like a good idea. There we go. Okay, so what's the risk of having a heart attack in 10 years? 10 people if they're not taking statins, and 8 people if they are taking statins, for people at average risk. So for someone who doesn't have really, a terrifically high cholesterol, isn't a smoker, and you can go through what makes you at a high or low risk, it's not that beneficial. And if we think about, again, what else is going on in healthcare, what are we required to do for the Oregon Health Plan, and what we will be required to do for everyone, which is reduce costs. It makes sense for the worried well to be aware of the fact that for them, taking a statin is not particularly beneficial. They may and really will get more benefit from exercise, from better blood controls than they will from a statin. It's 2 out of 100 difference, not very great. But then let's go back to the high-risk one. So here we have a picture of, these are people who are at high risk. And so this group, it really looks quite different. 12 people out of 100 will avoid a heart attack by taking statin. The baseline is no statin, 50 out of 100, and with a statin, 38. Now there is a much more substantial risk, but it also tells you this is not enough all by itself. So this is a really important kind of tool in helping people to understand that, that the benefits of a particular treatment, and the fact that you can't just say, oh, I'll eat anything I want, I won't exercise, I won't do anything else, I'm going to keep on smoking, I just need to take my statin. So I encourage you to look through this site. There are also other sites. There are a lot of tools, and I think there'll be more and more available to help you with talking with your patients and helping them to come to conclusions about what they can do and what they are willing to do and can follow through on to achieve excellent health. So this is just, I'm curious, when you do something like this, I want you to take this new blood pressure medicine twice daily. You think this is a very effective pitch, and is it what you usually do?
I believe, Kate, I think we're going to have a poll on this. We'd like to hear from you to see how you feel about these approaches. Kate, could you pull up that poll?
If this is all you said, I want, you've got high blood pressure, it's too high, I want you to start taking this medicine. Do you think that's going to be very effective? Why don't you do it with a yes or a no? And think about what you do. So the second one, would you like to get a pneumococcal vaccination? I can tell you for a fact that is what most people say. And when people switch over, when medical assistants switch over to your doc would like everyone to get a vaccination, I'd like to give you one today, the results change quite a bit. When would you like to get a vaccination? A lot of people say no. But when you've used the authority of the provider, a whole lot more people say yes. And what the MAs tell me is that when they do it this way and say, by the way, you're going to have to give in. If you don't do it now, I'm going to sick your doc on you. You get a much higher rate. So again, it's understanding the impact of the way you pose a question or the way you present your information is really, really important. And then this thing about you're 55 now, so you'll need to get a colonoscopy sometime before you're 60. Think about yourself. When are you going to get it? You know, pretty obviously it's going to be 59 for an awful lot of people. There'll be the people who jump right out and do it, but there are an awful lot of people who, when it's sort of open-ended like that, it's, sure, why not in 2015? That'd be good. I hear the prep is terrible. So very important to be thinking hard. How would it sound to me? How will it sound to your patient? Just run it through. And how will it sound to your patient? And how are you going to get them from there where they are of, oh my God, it's one more thing to do, to I need to do it. And the blood pressure one I think is an important one. Taking your blood pressure is important, and it's basically you have to take it every day to get the benefits. Is there anything that gets in the way of taking your medicines every day, every time? Because if you think about it, you can't take blood pressure medicine here and there. You really don't get benefits, and you will get the bad outcomes. So think about what you say, how you say it, and are you really making your best case? So, go. So just, you can look at these and you can see these later. Again, I mentioned the quit line, and I've talked about how to, about asking questions and making it easy for people to ask questions. So there are also other resources that will help you. Case management, email or automated telephone reminders, newsletters, using your portal to share information with people. And basically the bottom line is everyone can get better at this. This is not something you're born with. There are people who are born with it, but the rest of us can learn it. And you have the power to save lives and improve health, but you can only do it if you really work with your patients and they become a partner. Not a patient, but a partner. They are the ones who actually run their own care. We are only the coaches. So thank you very much. And now it's time for you to ask any questions.
We have a few questions that came in over the chat function, Dr. Medic. One of them is, how does shared decision-making impact providers working with patients with persistent mental illnesses?
People with mental illnesses are basically still people. And I actually have a long history. I worked with a lot of people who had anorexia. And that is certainly a very challenging group of people who have very fixed ideas. And you still have to do the same things. You have to understand their beliefs, and it's very often taking very small steps. And understanding that maybe with these people you won't be able to do this big treatment plan and then you're done for another month or 2 or 3 and they'll be coming back doing what you want. It may be, again, negotiating a very small thing. Like for instance, with anorexia, it may be eating one kind of food once a day in a small portion. And I can say that having had a lot of success with people with severe anorexia and bulimia, that it does work. But again, you have to sort of forget about your usual notions of how you're going to set out a treatment plan and go back to what is compatible with the patient's beliefs, what kind of small risk or small step they are willing to take, and to agree on that step and to do follow-up soon to, again, think of it as a test and how they did with the test. And David, you've done a lot of work with people who have mental illness. What would you say about that?
Sure, I agree with that statement. And as a social worker working as a therapist, I would say you're always taught to start where your patient is. You can't start advancing ideas or suggesting recommendations without knowing where the patients are, because they're not going to go anywhere. So I would agree with that.
Same holds with depression. Many people with depression actually do very well with therapy. They do very well with medications, but particularly if they have had a lot of therapy and they really do need medications, you have to overcome their fears of the medications. And I would say, once again, you may start with a subtherapeutic dose, because the goal is to get over the fear and work up to a dose that's effective, because the first goal is tolerance and willingness to take the step. So it's back to what David said, meet your patient where the patient is and make the progress the patient is willing to make.
We have another question. With the diminishing amount of time I am able to spend with patients, how can I be expected to make time to work through shared decision-making tools with the patient?
Okay, I'll tell you what one of my cardiologist friends said. He thought that in the past that his job was to tell people the 12 things they needed to do over the next 6 months. And he said what happened is most of them didn't do any of the things. And so he decided on a different plan and put it into place. He would do things like have, for heart failure, a sheet that had 4 or 5 possible things they might choose to work on. And he would do the basic exam and get the history, and then he would leave them with this and say, I want you to look at this and decide what you're ready to work on between now and your next visit. And then I'll come back and we'll go through that. And so that really shortened things up because they did their thinking when he was out doing something else. The other thing is, don't forget your MA or your case manager. You are not alone. I mean, that's one of the other differences between the old model and the new model. It is not the provider alone doing everything. You have a huge opportunity to take advantage of the skills, and you can train them, your MAs and your case managers, to work with people. Also group therapy, group visits. We did a very nice presentation on group visits because that's another way to bring in other players and also take advantage of the stories of your other patients that, again, may be more potent than anything you can say. When a patient says, here's how I handle this. When I go out to dinner, this is what I do. When I'm working and I'm away from the office and I need to exercise, here's how I handle it. So I encourage you to think about as we move forward, and you're going to be having to innovate. Think about considering some group visits.
Thank you. And I also want to remind the audience that if you would have any questions you would like to ask over your phone line, please raise your hand on the webinar, and Kate will be able to call on you. Kate, would you like to ask any other questions that are coming through on the comment line? Okay, we do have a third question here for you, Ruth. What are some strategies for getting providers on board with patient engagement strategies that may be reluctant to speak when patients as equals?
This is not unheard of. This is a pretty common thing. Again, it's how you were trained, what you're used to doing. My patients trained me. I had patients a lot like all of us in the room who early on made it really clear that they were just as smart. They just didn't have as much information, and they were perfectly capable of making decisions. So I guess looking at your patients and thinking that could be me is the first start. Or going to your own doctor and thinking about how does it feel to be treated like a patient. Or you could do it with a parent or a child. I think that if you come into those with, as the observer, thinking, what does this other provider sound like when they talk to me? How do I feel when they talk to me, at me, instead of engaging me in decisions, instead of asking, does this sound like a plan I can live with? I think that kind of introspection will really help people to craft a new relationship with patients. And it isn't for every patient. There are patients who simply want to be told. But in our culture, more and more people don't want to be told. They go to the Internet. And so with the Internet, those of you who have patients who do that, you need to find the sites that are good. Find the sites that are reliable and direct them to those sites, because there's a lot of garbage on the Internet, but there's also a lot of really good quality information. So again, recognize your patients are not coming in the way they did 20 years ago with no information. They may come in with a lot of information and expect to be treated as an informed individual. And they may know as much as you do about some of those subjects.
Thank you, Ruth. Another question we have is, how do you recommend managing chronic pain patients? And this is a very difficult population,
yes.
and as we see, there's a lot of attention to adverse drug events, and providers may be reluctant to working with some of these patients? And what kind of strategies do you have?
Well, actually, I was just at the governor's conference the other day, and everybody is working on this. This is a really difficult thing. You know, one of the problems is that chronic pain is often a sort of central pain thing. They're sort of differentiating. But the most important thing in giving medications for chronic pain is understanding whether you're improving function or not. Pain medications that result in people walking more, going to work every day, or whatever kind of function, improving function, have value. If they're not improving the function, you probably shouldn't be using them. The other thing is that the only way to treat chronic pain is not just opioids. There are the various other adjuvants, such as the gabapentin and the Lyrica. They're not horrendously beneficial for neuropathic pain. They help about 1/3 of people. But exercise is very beneficial. Antidepressants are very beneficial. Sleeping, getting good sleep is terribly important. And therapy, group stuff, whether it's a group exercise class or a support group. Again, those can be incredibly, incredibly important. So don't just think pain medicine. It's one thing. I do hospice, so it's a different group. But even there, we use adjuvants. I forgot to mention the tricyclics. We use adjuvants. We use antidepressants. We use therapists, that is medical social workers. We engage chaplains, because very often there are really big issues that have nothing to do with just the physical pain. So really important to be thinking more broadly than just pain, opioids. Even just understanding, what was really going on? What does the pain mean to that person? So I'm going to quit because that's a whole day topic. And if you don't know what to do, remember there are pain specialists, although I would say one of the problems is many of the pain specialists are totally linked into procedures. And so that I don't know where we're going to end up going with that. But big subject, big problem. So what's the best way to involve office staff, clinical, in helping to coach patients? I was in a diabetes office one day, and I noticed that everybody in the office was paying attention to the patients. When they walked in, they noticed if they had lost weight, if their A1Cs were good, and so they gave a huge amount of positive reinforcement to patients. The other thing you can do is you can give them scripting. For instance, if it's for a preventive service, you can give them scripting about how you feel about, for instance, doing colorectal cancer screening and how important it is, and so that they can essentially carry the message that you recommend a test and they talk to the patient about this. Or blood pressure. Again, if a lot of your MAs are frankly underemployed, they are smart enough that if you give them scripting about what to talk with about patients, they can do a fabulous job. Think about the patient navigators. They get a modest amount of treatment and they get minimal supervision. So if they can do it, so can your MAs. And you are right there to coach them, right there to observe how they carry out that coaching and to modify it. So essentially, they are not prescribing without a license. They are carrying your message of education and of encouragement.
Thank you, Dr. Medic. And I'd also like to thank all the callers for these great questions. Unfortunately, we're running out of time. We're not going to be able to get all of them. But the questions that were asked, we will get back to you by email, and we will take a look at those. We also wanted to share with you a few practices that we're working with at AcuMentor Health who've done a great job in patient engagement and have also been recognized as Tier 3 medical homes. And if you'd like to contact any of these practices, please get a hold of me, and my contact information will be at the end of this webinar. We also, when you drop off from this webinar, we would love to hear back from you how we can better serve you as we move forward and as the PCPCI Institute moves forward with future webinars.
And I want you to really think right now, this is a good time to think about, are there 2 things you could do differently in your practice that would engage your patients better, get them more involved in care decisions, and in actually adhering to a care plan?
Thank you. And here's our contact information. We also would like to remind you that there will be additional PCPCI webinars coming up, so stay tuned and please check your email. You'll be hearing about these updated webinars soon. I'd like to also thank everybody on the call today. And if you have any questions, please contact us or PCPCI. Thank you very much, everybody.